Good afternoon, everyone. Dr. Ravi, Pediatric Department. I'm dealing today about the approach to cholestatic jaundice in children. Cholestasis is defined as impaired bile flow resulting accumulation of bilirubin and bile acid in the blood and extrahepatic tissue. Is defined as more than 1 mg of direct bilirubin when total bilirubin is less than 5 mg per deciliter, or 20% of the bilirubin if the total bilirubin is more than 5 mg per deciliter. Neonatal cholestasis onset usually we consider as if the persistent direct bilirubin jaundice persistent more than 2 weeks in a term child up to 3 months. In preterm, beyond jaundice more than 3 weeks to 3 months. Usually the children present with a yellow color discoloration of eye, skin, high color urine and staining of diapers, plus or minus clay color stools. They may present with neurological abnormalities like irritability, lethargy, seizures, poor feeding, hepatomegaly, growth retardation, and coagulopathy. Antenatal history during first trimester gives some clue. If the mother had fever, rash, lymphadenopathy, we can suspect torch infections. If the mother had jaundice during third trimester with pruritus, we can think of about Pfick disease or BRIC. Some clinical clues will give for the diagnosis of etiology in cholestatic jaundice. If the child presenting with a cataract, failure to thrive, sepsis, especially E. coli with hypoglycemic episodes, possibility of galactosemia, child with small for gestation, skin rash, purpura, PTK, cataract, microcephaly, thrombocytopenia, all these clinical features along with the first trimester antenatal fever in mother that gives clues about the torch infection. Any child presenting with a short for gestation, early coagulopathy, sick child with a history of antenatal oligohydramnios, megaplacenta, recurrent abortion gives clues about the neonatal hemochromatosis. Antenatal history of pruritus in third trimester suggestive of PFIC. Disproportionate splenohepatomegaly can think about Niemann-Pick disease. Healthy child with hepatosplenomegaly with a dark color urine, clay color stool, possibility of biliary atresia, papimal mass in the left hypochondrium on USG examination, possibility of choledococcal cyst. Any dysmorphic child like broad triangular faces with heart murmur, hemivertebrae, butterfly vertebrae, or posterior embryotoxin, Alagale syndrome, bilious ascites, spontaneous perforation of bile duct, lax skin, limb abnormality, orthogryposis, any neurological abnormalities like irritability, lethargy, poor feeding, hypotonia, seizures, eye abnormalities, sibling death, consanguineous marriage, can we think about a mitochondrial disease or metabolic disorders or hypothyroidism. So these are the common causes of cholestasis. In this, infection causes UTI, especially in children with galactosemia, they can present with a sepsis. Common viruses can cause cholestasis like CMV, torch infections, uh, and tuberculosis. Obstructive diseases like cystic bile ducts, biliary atresia. In a preterm, total parental nutrition, all these things can cause cholestasis. In metabolic disorders, hypothyroidism, altered bile acid metabolism, thyroxinemia, galactosemia, glycogenesis, cystic fibrosis, growth hormone deficiency, cortisol deficiency, alpha 1 antitrypsin deficiency, syndromes like Elegale syndrome and Pfick disease, and trisomy Down syndrome, other Niemann-Pick diseases. All these are common causes of cholestasis in children. How to approach a child? If the child is presented with a persistent cholestasis more than weeks to in children, usually we need to do basic investigations like LFT, GGT, PT, INR, septic screen, and ultrasound abdomen. If the septic screen is positive, like urine or blood culture, treat accordingly. As per the specific history and examination findings, we can do a specific test like HIDA, liver biopsy, metabolic workup, endocrine causes, bone marrow, and genetic testing. LFT-INR confirm the conjugated hyperbilirubinemia and synthetic function. High transaminitis may be indicative of infective hepatitis. GGT is more specific than alkaline phosphatase because alkaline phosphatase increase in vitamin D deficiency. High GGT indicates the biliary tract involvement. So these are the normal values of GGT in infant according to the age. In Alagilla syndrome and sclerosing cholangitis, usually GGT is markedly elevated. Ultrasound abdomen will give clue about the anatomical abnormalities. If the common bile duct diameter is more than 4 mm, indicate colorectal cyst. If the gallbladder is less than 1.4, 1.9 centimeters, contracted gallbladder after 4 hours of NVM, that indicates biliary atresia. You can identify splenic malformations in ultrasound with ascites. HIDA scan is only to exclude the biliary atresia. It will be helpful. Liver biopsy gives clinical diagnosis. In biliary atresia, bile duct proliferation, you can see bile duct proliferation, portal fibrosis, intact hepatolobular architecture. The diagnostic accuracy about 90% to 95%. In neonatal hepatitis, you can see giant cells transformation, variable inflammation, focal hepatocyte necrosis. In metabolic and storage disorders, specific cells you can notice. And a viral infection, viral nuclear inclusions, we can see in a liver biopsy. This is the chart about the flow chart about the cholestasis. Any child presenting with a jaundice, with a diaper staining without pale stools, do one LFT, look for conjugated hyperbilirubinemia, give one vitamin case and other supplementation. If the child is sick, do one septic screening. If the sepsis is positive, treat accordingly. If the septic screen is negative, and clinical examination gives some clues like conjugated hyperbilirubinemia, short for gestation, low birth weight, sibling death, hepatosplenomegaly, cataract, and coagulopathy. You can look for other causes like metabolic liver diseases, galactosemia, thyroxanemia, neonatal hemochromatosis, specific infection like torch infections, and other infiltrative disorder like hemophagocytosis. If the child is non-sick and jaundice is persistent with hepatosplenomegaly growing well, look for pale stools for 3 consecutive days. If the pale stools are there, look for biliary atresia and colorectal cyst and do specific investigation. If the child is non-sick and active growth is adequate, look for stools pigmented or not. If the pigmented stools, these are the common causes like PFIC disease, Alagilla syndrome, bile acid synthesis defect, or alpha 1 antitrypsin deficiency, Down syndrome, and endocrinal causes like hypothyroidism. How to investigate these children? In the sick child, look for septic screen, urine for non-reducing glucose, like Benedict test at bedside. If it is positive, do GALT assay, which confirms the diagnosis of galactosemia. Alpha fetoprotein, urine succinyl acetone, which indicate thyroxanemia. High ferritin levels, which gives hemochromatosis, and torch profile will give clue about the torch infection. And according to the clinical situation, in hemochromatosis, we can do lip or cheek biopsy to confirm the hemochromatosis. If the child is non-sick, get one ultrasound abdomen, HIDA scan, liver biopsy. If inconclusive, go for cholangiography. In pigmented stools, commonly the genetic tests are useful. Alagilla syndrome, echo, eye examination, and an X-ray, dorsal spine. There is a hemivertebra. Genetic testing will help to the diagnosis. In storage disorder, bone marrow will helpful. Endocrine, look for hypothyroidism. Chromosomal abnormality, karyotyping, and Down syndrome will help the diagnosis. In galactosemia, usually the specific therapy, lactose-free formulas. In other conditions, maybe specific therapy or liver transplant is ultimately the uh, child need to go for transplant. In suspected biliary atresia, Kasai procedure is the final. To differentiate diagnosis of cholestasis in decompensated liver failure, look for sepsis, metabolic workup, specific infections like torch, and inflammatory disorders we need to keep in mind. Regarding the progressive familial intrahepatic cholestasis, in this condition, usually the serum GGT will be normal in type 1, type 2, but it will be elevated in type 3. And pruritus will be severe in type 2, and rapid progression will be there in type 2. Alagala syndrome is a characteristic feature of broad face, triangular, broad forehead with a small chin. Hypertelorism, it's called as a triangular faces with hemivertebra and cardiac murmur. All these classical features of Alagala syndrome. And severe cholestasis in infancy progress till up to 5 years, then improves. Mild cholestasis in Alagala syndrome will not progress. Pruritus is the main manifestations. And genetic test, GAG1, Notch2 mutation will confirm about this syndrome. About the galactosemia, the deficiency of galactose 1 phosphate uridyl transferase, mainly the liver and CNS damage will be there, mainly presented with E. coli sepsis, jaundice, organomegaly, ascites, hypoglycemia, especially hypoglycemia post-feed. Children will have hypoglycemia. Usually, the children will have hypoglycemia before feed. In this situation, in particular galactosemia post-feed, the child will have hypoglycemia. So that is the main clue, and along with the cataract. So look for galactose activity in RBC therapy, especially galactose-free diet, and early initiation will give excellent outcome. In hematochromatosis, usually child present with this coagulopathy is severe with jaundice. Usually, child will be sick. In thyroxinemia, there is a coagulopathy, transaminase with no jaundice in some conditions. Liver failure, rapid decompression with death unless prompt treated. So NTBC and thyroxine-free diet will be helpful. So these are the common drugs we use to support neonatal cholestasis babies: vitamin K, vitamin D, vitamin A, and vitamin A, and water soluble supplementation. Child may require 120 to 150 kilocalories, normal requirement, and protein 1 to 2 grams per kg per day. You need to use MCT powder oil, MCT oil 1 to 2 ml per kg per day. You can give in 2 to 3 divided doses. Drugs commonly used for pruritus, these are Yodca, rifampicin, phenobarbital, cholestyramine. We commonly use Yodca, rifampicin, and phenobarbital. We commonly use less cholestyramine. So these are the common presentation for the neonatal cholestasis. So in infantile thyroxinemia, primary fatty oxidation deficiencies, hereditary fructose intolerance, glycogen storage disorder. In childhood, usually Wilson disease presentation. In early utero, fatty oxidation deficiency is long chain, and in neonatal chromatosis is the early presentation. In neonatal galactosemia, Ullmann's disease, and citrin deficiency, bile acid defects. All these are common presentations about the cholestasis.
Good afternoon, everyone. I'm Dr. Mansa from the Department of Hepatology. Today, I'll be speaking about pediatric cholestatic syndromes a little bit in detail. So, coming to the broad classification of cholestatic syndromes, we first need to divide them into either intrahepatic disorders or extrahepatic disorders. The extrahepatic disorders include choledochal cyst, Caroli's disease, biliary atresia, and cholelithiasis. Intrahepatic, broadly, we can classify them coming under infections. The most commonly we'll see are torch infections, CMV, and HSV infections, which can be seen in neonates. And second are endocrine disorders, genetic mutations, and neonatal hepatitis. Neonatal hepatitis again is an overlapping term and is a very broad term which includes a wide variety of disorders. Today, for our presentation, I'll be focusing mainly on the genetic mutations and in particular regarding the inborn errors of bile acid synthesis and metabolism. Coming to the epidemiology of neonatal cholestasis syndrome, in this study conducted in India in 1996, out of 60 infants who presented with NCS, 33 infants were found to have biliary atresia. That is, the most common presentation so far in neonatal cholestasis is biliary atresia. Once that is ruled out, 14 out of 60 patients, that is 23%, presented with neonatal hepatitis. It is again a broad term involving infections and other disorders as well. And 3% of patients presented with paucity of intralobular bile ducts, and 11 patients were of indeterminate etiology. And in another study, which was in 2016, out of 100 patients, 35 were secondary to biliary atresia, and idiopathic causes were 25 patients, sepsis, UTI were 20 patients, and PFIC and paucity of intralobular bile ducts were only 4 patients. That is, maximum is from biliary atresia, followed by idiopathic causes, and a very small proportion is by PFIC and other conditions. In this study, they have analyzed the etiologies before 2000 and after 2000. And it was the significant findings were that transient cholestasis seemed to increase in the recent years. That could be, the causes could be secondary to low birth weight, prematurity, asphyxia, usage of TPN, and sepsis. And whereas, as we can see here, alpha-1 antitrypsin deficiency has decreased. That was higher before 2000, but however, the onset on identification of this disease is much lower in the recent years, probably because of much more advances in the treatment strategies for this condition currently. Speaking briefly about bilirubin metabolism, these are the hepatocytes, which is a basolateral membrane, and bilirubin usually in the plasma will be bound to albumin, which will be bound reversibly. And this bilirubin uptake will be happened by diffusion and it through the basolateral membrane into the hepatocytes with the help of UGT1A1, and it will be conjugated to bilirubin glucuronides. And this conjugation is an important step for excretion of this bilirubin into the bile. And these bilirubin glucuronides will be excreted into bile with the help of MRP2. And a small component of these glucuronides will be effluxed out of the hepatocytes through MRP3, and these effluxed glucuronides will be further taken back with the help of OATP1, B1 and B3. Now, for the excretion of these bilirubin glucuronides into the canaliculus, we also need bile salts. And these bile salts, they will be excreted and secreted rather through bile salt excretor pump, and which is coded by ABCB11 gene. And along with this, in order to maintain the integrity of this biliary canaliculus, we need certain phospholipids and proteins, which are aminophospholipids and phosphatidylcholine. So ATP8B1 and ABCB4 are the genes which are involved in maintaining the integrity and for transcription of these proteins. And for our presentation today, the genes mainly involved are ABCB11, ATP8B, and ATP-ABCB4. Just a brief word about alpha-1 antitrypsin deficiency. These patients mainly have bimodal presentation, usually seen between 4 to 6 weeks at birth, and later further they can also progress to have cholestasis and further liver disease as well. And that is mainly because of a point mutation where there will be a misfolded protein which will be accumulated in the endoplasmic reticulum, and these will lead to further polymerization and further because of gain of some toxic mutations, it will lead to further liver damage, and it is also known to associate with emphysema and is also a risk factor for HCC. HCC development is commonly seen in patients with alpha-1 antitrypsin deficiency. Some patients can spontaneously improve, and diagnosis is done by phenotype testing. And although there is no specific treatment so far, mainly supportive nutritional therapy for all the vitamin deficiencies management, and LT can be indicated in cases of progressive liver dysfunction. And however, newer therapies are coming up where certain genetic therapies and autophagy enhancing genes, they are under trials like carbamazine, other drugs which are under trials, which are being tried in these conditions. Now, coming to defects where bile acid synthesis is affected, any of the enzymes which are involved in the bile acid synthesis are affected, that can lead to these disorders. And they have been classified as congenital bile acid synthetic defects from 1 to 4. And type 2, that is the only condition which is associated with increased GGT levels. Other conditions are associated with low or normal GGT. And type 4 is associated with motor neuropathy, and it can have an adult onset phenotype as well. And coming to type 1 can present similar to PFIC, but it is associated without pruritus, although it is low GGT and bile acid synthetic defect, but no pruritus in this condition. And these disorders should be considered in any child with persistent intrahepatic cholestasis. And the clue is that there will be low bile acids and high direct bilirubin. The difference between these disorders and bilirubin metabolism disorders are that they will have high bile acids. These are the condition with low bile acids and high bilirubin levels. And diagnosis is by urine analysis for metabolic precursors, by mass spectrometry, and treatment is by oral cholic acid therapy can be given for supplementation. Now we have discussed the inborn errors of bile acid synthesis. Now we will go for bile acid transport defects under the headings of mechanisms, types, and we'll have a brief look at the available literature and the management. That is now, as we have just discussed regarding the various bile acid pumps and the associated conditions, now coming to PFIC type 1. PFIC type 1 is a condition where aminophospholipid, which is needed in order to maintain the integrity of the biliary canaliculus, that will be inhibited for movement from inner layer to the outer layer. So that is FIC1 gene is the one which is affected in this, and hence aminophospholipid also will be affected. PFIC type 2 is a condition where bile acid exporter pump is the one which is deficient in this, and hence BSCP deficiency will be seen in PFIC type 2, which will lead to increased bile acids causing PFIC 2. Coming to PFIC 3, PFIC 3 is again by ABCB4 gene, and there will be a lecithin is what is involved, again structural integrity protein for biliary canaliculus, and the deficient pump is MDR3 pump. And along with this, now we also have new types of PFIC where FXR has been identified as one of the contributing factor, where there is a homozygous loss of FXR can also lead to a type of PFIC. And TJP2, that's another tight junction protein 2, that is the gene which is encoding the TJP2 also leads to another new type of PFIC which has been identified. Now, what are the common conditions? What are the common clinical features in all these bile acid defects? They will have jaundice, pruritus is common, there will be failure to thrive, fat-soluble vitamin deficiency, they can progress to cirrhosis in 5 to 10 years, and finally they progress to liver failure. But what are the differentiating features between each of these types? So as a rule, only PFIC type 3 is the only condition in this which will present with high GGT cholestasis. Rest everything is with low normal or low GGT cholestasis. And PFIC type 3 also has an increased risk of HCC and cholangioCA, and increased intrahepatic stone formation. And coming to PFIC type 2, it is a very rapid progression, early onset, it is a more severe form of disease, and less than 15% rate of malignancy, and it can occur in children as young as 13 months. PFIC type 1, it also has extrahepatic manifestations. That will be the clue for diagnosis, where the patient can have pancreatic manifestations, diarrhea, hearing loss, etc. And the other new types, PFIC type 4, PFIC type 4 usually presents with severe cholestasis and pruritus. It is also a very severe form with rapid progression. Neurological and respiratory deficits are also seen in this. That is the tight junction protein associated PFIC. And coming to PFIC type 5, that is the FXR associated PFIC, also has rapid progression to end stage liver disease. And PFIC type 6, this is seen in conditions which are associated with, which may or may not be associated with microvillus inclusion disease, and they can be varying forms of presentation, including transient, progressive, or recurrent. In this series, where from India, where 24 cases of PFIC have been studied, the most common PFIC is found to be PFIC type 2. That is the most severe form, and rapidly progressive form is the most common identified. And the median age of onset is at 3 months for PFIC 1 and at 5 months for PFIC type 2. Now, coming to PFIC type PFIC type PFIC type 2, that is a severe form. We also need to identify which is the subtype of this PFIC type 2 which is causing the severity. So they have done this genotype correlation in this study, where they have identified 3 different genotypes in PFIC 2, that is BSAP 1, 2 and 3. And they have identified that patients with BSAP type BSAP type 3 is the most severe form of PFIC type 2. The median age of survival in those who had BSAP type 1 is 20 years, and BSAP 2 is 7, and 3 is 3 years. And they also had higher risk of hepatocellular carcinoma in those with BSAP 3, that is 34%, compared to only 4% in type 1. That is, in PFIC 2, those genotypes with BSAP 3 are more severe, and higher risk of HCC have been found. And they also found that the serum bile acid concentration, if it is decreasing to less than 75% after biliary diversion, which has been offered in this, they found to have a native liver survival of more than 15 years following this biliary diversion. Coming to PFIC type 4, wherein the tight junction, the gene encoding the tight junction protein 2 is involved. In this series, 12 patients with this condition have been studied, and out of which 11 were with consanguinity, and the median age of presentation was 2 months, and 11 out of 12 patients presented as neonatal cholestatic syndrome, and 9 required LT, and the histology showed non-specific features with intracellular cholestasis and giant cells. Now, coming to PFIC type 5, normally FXR, it is a bile acid nucleic acid sensing receptor, where it senses when there is increase in bile acids in the body, and that will further inhibit the hepatic bile acid synthesis. But now in this PFIC type 5, in this study which was published in Nature in 2016, they have identified a newer subtype which presented with low GGT cholestasis. They also had BSEP and MDR3 deficiency on immunohistochemical staining. But however, on further genetic analysis, they found that there was a complete homozygous loss of FXR, and also found to be a direct target for ABCB11, which is encoding PFIC2, and ABCB4 encoding PFIC3. And the phenotypes in this study were found that earlier onset of liver disease and very rapid progression, and 5 out of 8 patients expired, and 3 needed transplantation. That is, PFIC type 5, which is associated with FXR homozygous loss, is a very severe and early onset presentation. There's another PFIC which has also been identified, that is PFIC type 5. Normally, microvillus inclusion disease is a condition which there will be an intestinal condition where there will be a lot of diarrhea in the patients, and most common complaint will be diarrhea, and they will be treated with total parenteral nutrition. And cholestasis will be associated in this condition, either secondary to the disease or secondary to TPN. But in this study, they have identified that in those patients with myophoebe mutations, it can cause normal GGT cholestasis even without association with microvillus inclusion disease. That is, 5 patients have been identified who had pruritus and with recurrent bouts of cholestasis, and partial external biliary diversion has been offered to these patients and which showed relief of pruritus. So this is another new type of PFIC where myophoebe mutation has been seen without being associated with microvillus inclusion disease. And this is a similar study where they have studied myophoebe disease features. The median age is found to be 19 months, and the presenting features were jaundice with pale stools, and 3 patients underwent biliary diversion, and 1 patient underwent liver transplant with a median follow-up of 5 years. Now, coming to the management principle, we need to optimize the nutritional status in these patients with supplementation of fat-soluble vitamins. And the most important would be pruritus management. The first line would be ursodeoxycholic acid at a dose of 20 to 30 mg per kg, along with cholestyramine at a dose of 200 to 300 mg per kg per day. And if there is no improvement within 1 month, we switch over to rifampicin at a dose of 5 to 10 mg per kg per day. Certain studies have also shown usage of naltrexone, and if no response, further ondansetron also has been tried. There are other certain surgical procedures which can be offered in certain types of PFIC, that is biliary diversion and ileal bypass. There are various types which include partial external biliary diversion, partial internal biliary diversion, total biliary diversion, and ileal exclusion. Now, partial external, these biliary diversions can only be offered in PFIC type 1 and type 2, where who have not progressed to fibrosis grade 3 or grade 4. But it has been shown to decrease the pruritus and also improve in the stage of fibrosis. And also to note that these biliary diversions should not be offered in patients with PFIC type 3. These are the various studies on biliary diversion surgeries, where from 2006 to the latest study in 2018, where a partial external biliary diversion has been shown to improve the biliary biochemical parameters, improvement of pruritus, and also improvement in fibrosis in certain conditions. Our take-home points are that wide spectrum is seen in cholestatic syndromes, treatable types to be identified earlier, new types of PFIC are being identified, and high GGT is only seen in PFIC 3. Liver biopsy and genetic analysis can be used to identify the types, and pruritus management and nutritional optimization is a key. Biliary diversion procedures may be offered in low GGT cholestasis with early stages of fibrosis. Thank you. Yes, sir. Check.
Good afternoon, everyone. I'm Dr. Ravikant. I'm asked to talk about the pediatric cholestatic the genetics perspective. The mechanism also I am supposed to talk, but since Dr. Manasa has elegantly demonstrated, I'll just speak about what are all the panels that are available, both in-house as well as what we. Again, the definition has been given. So I'll just spend 1 minute on this slide because this is a very good review that summarizes the entire mechanisms in cholestasis with respect to the genetics and the proteins that are involved. So it is summarized elegantly here. Say, for example, bile acids are synthesized from cholesterol by a gene called CYP7A1. They are transported into the canaliculi through the BSEP. And liver storage of bile acids leads to liver injury, itching, and increased risk of hepatobiliary cancers. Likewise, all the others are elegantly summarized in this cartoon, and all the genes have been mapped. I'll not spend much time here. And The genetic cholestatic liver disease is basically organized by the mechanism of disease causation and the presence of extrahepatic findings, basically into three types. One, the disorders of transport of bile acids or phospholipids. Two, the disorders of bile acid synthesis, and disorders with extrahepatic metabolic or developmental findings. Now, disorders of the transport of bile acids or phospholipids, basically there are around 9 genes that have been mapped, right from PFIC 1, 2, 3 and the others. So this is basically offered as a panel for genetic testing. The other is the disorders of bile acid synthesis, where 6 genes have been mapped, which are congenital defects in bile acid synthesis. Again, these 6 genes are offered as a gene panel for genetic testing. The other is the cholestatic liver disease and extrahepatic findings. It's a list, a long list. Again, these are put together as a panel and they are offered as a genetic testing. Now, the evaluation strategies to identify the cause of a genetic basis underlying cholestatic liver disease in a proband, apart from the medical history, physical examination and laboratory testing, two very important points. One is taking the family history and the second is ordering a genetic test. Now, in the family history, it's always good that you take a 3-generation pedigree. This is basically to understand what type of inheritance pattern is probably seen in the proband. Basically, two types: autosomal dominant, autosomal recessive. Based on the pedigree that you collect, you can estimate. And once the genetic test is returned, depending on the result, you can estimate the risk in the future generation. So it's absolutely required that you take a 3-generation pedigree. Now, with respect to the genetic testing, the options available are targeted gene panel, clinical exome, and a whole exome testing. Basically, targeted gene panel is, I've shown you a list of genes that are associated. You can just sequence those particular genes and see if there are any variants. That's more of a focused way of looking at things. When do you order this test? If you are very confident about the phenotype, go for a targeted gene testing. On the other hand, you have an unbiased way of looking at the exonic regions, something called as a clinical exome sequencing or a whole exome sequencing. This basically, if you want to rule out or you have an overlap of symptoms between 2 or 3 different kinds of syndrome or this thing, you can basically order this unbiased kind of a test. So it's always good you go for a whole exome sequencing, because clinical exome has a subset of genes from the whole exome sequencing. And in case it returns negative, you'll have to again go for a whole exome test. So it's always better you go for a whole exome and do a comprehensive evaluation of all the genes that are available. Now, we have few in-house panels for the PFIC 1, 2, 3 testing. That is, if you are very confident about the phenotype and just want to do a targeted testing, say for example PFIC 1, you can order this particular test. Or in case you want to do all the 3, you can do a combined panel. That is, we put together all the 3 genes and offer it as a panel, PFIC 1, 2 and 3. And of course, as I said, you can also go for a whole exome sequencing in case you want to do a more comprehensive testing. In-house, we have tested almost around 30 samples till date, and we see that we find both variant of uncertain significance, which is there, the first variant which is listed there, and also the pathogenic variants which are there. We see both autosomal recessive, predominantly autosomal recessive, but autosomal dominant also in few of the cases. So there, if we take the pedigree information, it will always be helpful. The other thing, of course, the emphasis is on post-genetic testing. Once the test report is returned to the patient, of course, it's very important to understand the modes of inheritance: autosomal dominant, autosomal recessive. That is because to ascertain the risk in the SIPs or the other family members, of course, screening of the SIPs is also recommended. Then there's a 25% risk in case it is an autosomal recessive and a 50% risk in case it is an autosomal dominant kind of an inheritance pattern. And offspring of the proband, screening is recommended in the partner in case they are not married and they wish to get married. This is something called as a carrier testing. This is also recommended. And then prenatal testing and pre-implantation genetic testing is also recommended in case a screening test is not done prior to marriage. Thank you for your patience. Question? Mostly all of them are autosomal recessive, but for one or two types which are autosomal dominant. Definitely it will help because in the proband, if in case if the other partner we screen for the same variant and if found normal, then there's no risk in the next generation. If she or he is heterozygous, then again there's a 25% chance because it is autosomal. Again, you can do a pre-implantation testing to rule out whether it is there in the fetus. It's always good we understand the type of inheritance. Whole exome identifies everything, including the all the three PFIC 1, 2, 3, and all the newer genes also it identifies.
Phenotypic difference in does it say that the same gene is affected both break? So why the phenotypic difference is there?
That's where probably some clues we can get from the whole exome sequencing because any other genes or any interactions with the other genes can be identified with whole exome. If you're doing a targeted sequencing, the type of mutation profile is similar in two different patients, but the phenotypic expression is different. Probably there's some other gene that is influencing this. So probably we can get an indication if we do a whole exome.
So, sir, if we get patients with cholestatic presentation in the neonates or early child, so if we get a whole exome sequencing, will it then getting a lot of batch of tests? It will be easier for us.
Uh, if it is a straightforward, it all depends how confident you are with the phenotype. Your phenotype is very strong, it's easy to get a genotype. So yes, you do a whole exome sequencing in underlying very strong phenotype, we are likely to get a genotype. Thank you.
Actually, this topic basically pediatric cholestatic syndrome. Lots of patients they have been doubts how to manage these patients of cholestasis. That's the reason we kept this hospital. Great enthusiasm from the clinicians actually. Anyway, which is a common problem for us. Most of the patients who come to our department with cholestasis, itching, in dealing with sleep, itching has not gone. Reason we wanted orbit disease actually. And Dr. Ravi had Ravi from pediatrics. Dr. Thanks a lot for great presentations. We think what we see is common. This cause of the cholestasis is said to be cholestasis, but in AIG we don't see that often the cause of cholestasis. We see unusual causes of cholestasis. Okay, thanks a lot for just the participation.